صباح الخير على الجميع. Thank you, Dr. Najwa, for the invitation, and thanks for the attendees for being here early in the morning. Today, I'm trying to make it really short and to the point, where we're going to talk about the new approaches in management of relapsed refractory diffuse large B-cell lymphoma. So just looking at the morphological distribution of non-Hodgkin's lymphoma, which is one of the most common types of cancer among female and male in Saudi Arabia, about half of those patients with non-Hodgkin's lymphoma are diagnosed with diffuse large B-cell lymphoma among both genders, female and male. And that's give us a perspective about the burden of the disease among patients in the kingdom, and the importance of having therapeutic options for our patients. So diffuse large B-cell lymphoma account for 25% of all types of non-Hodgkin lymphoma generally, and as we see in Saudi, it's around 50% among all genders, and usually it's diagnosed around 64 years old median age, and the survival depends on the risk factors. We usually calculate the IPI risk score. It's possibly curable disease, and we always target for cure. However, patients have refractory disease, and we're going to talk about how to treat those patients. Some genetic abnormalities can happen, including BCL6 and BCL2 and MEK mutations and so on. Common chemotherapy regimens are the R-CHOP regimen, and it was studied in this French trial.
Afwan, Dr. Nora, can you maximize the slide, because we just see the first slide?
Oh, I'm sorry.
Maximize and just get to the next slide.
I don't know if you can see it now.
Yeah, but not yet maximized.
Oh, let me see.
Can you make it full screen, please? Yes.
I will. Maybe I need to stop it and return back. Can you see it right now or no?
No, not in full mode. Can you make it press F5?
That's just give me a second. Let me try.
Yeah, now
maybe
it's
I just
okay.
need to share my main screen. Okay,
yes,
perfect. Thank
okay.
you for letting me. Okay, so I was talking, let me minimize this. Okay, this is the percentages here among male and female, as I said, and then if you can see the incidences and age and survival for those patients. And then secondly is the R-CHOP regimen, which is despite a lot of advances and trying to use targeted agents, R-CHOP regimen stayed as the main, I would say, cornerstone of therapy in diffuse large B-cell lymphoma as a first line, although some data are emerging, and we still consider using dose-adjusted EPOCH with patients with aggressive lymphomas who can tolerate dose-adjusted EPOCH. However, with R-CHOP regimen, we can see that only 65% of those patients get cured when used this regimen. So around 25% of patients have relapse, and then have relapse disease, and then also patients have refractory disease, around also the same percentage, 60% within 5 years. So when we look at the NCCN guideline and what they recommend basically for relapsed refractory disease, which is not a small segment of those patients, they recommend that you look for the transplant criteria for those patients. Are they can you transplant those patients or not? So if those patients can be transplanted, which is over here, you proceed with the second line therapy, and we're going to choose, and I'm going to show you the type of options, and then you can basically, if patients have complete response, partial response, or no response, you can basically choose the therapy. If they have complete response, you either use autologous stem cell transplant or allogenic stem cell transplant plus minus radiation. And then if they have partial response, CAR T cell is recommended or basically any patients who have refractory disease or any patients who have cancer, generally speaking, enrolling them in clinical trials internationally in the European region or the United States is highly recommended. We have some limitations over here, but we try our best to do allogeneic stem cell transplant or autologous stem cell transplant, depend on the patient status and what we have in our institution. If patients are non-transplant candidate for either age or any other failures in their organ system, basically enrolling them in clinical trial or using palliative regimens or second-line therapies that we're going to discuss are generally recommended. So when we look at this slide, if you have a patient with an intention to proceed with transplant, you either choose DHAP regimens. I know that a lot of our institutions use that regimen. ICE regimen, ESHAP also can be used. And those are generally recommended. There's no one favorable over the other. And as I said, some subsegment of patients who had response or partial response, you can use CAR T-cell, which is not available. So I'm not going to spend a lot of time talking about it. Also here for non-transplant candidates, which I'm going to focus on today because it's the new approval and it's coming up to be approved in Saudi soon, which is the polatuzumab plus bendamustine and rituximab. I know some of my colleagues used it in a compassionate use, just like us. So we've seen it and we've seen our patients received it. So it will be a nice discussion to talk about it. And then ibrutinib in some small segment of patients who had non-germinal cell, and it's recommended for younger patients also, and then lenalidomide, but those are can be recommended and they are not favorable over other regimens, but in certain circumstances they can be used. Third line or subsequent regimen is this new drug who's has been approved in June 2020 in the United States, selinexor, if I'm saying it right, because it's a new one. But selinexor, we're going to talk about it a little bit, and it's approved based on a phase 2 trial. So here is the polatuzumab, which I'm going to talk about, which we have been using in Saudi Arabia a little bit and under compassionate use, and it's going to be approved by Saudi FDA. It's a humanized monoclonal antibody mAb, and it's targeting the B cell antigen receptor complex associated with protein beta chain, the CD79B, as you can see over here. So it's conjugated with MMEAs, just like some of the other agents over here. And you can see that through the engineering, this agent is linked to the monoclonal antibody. So upon administration of the polatuzumab, selectively bind to the CD79B, which is the protein abundantly expressed in the B cell membrane, as you can see over here. And basically what happens is that the cleavage happens to the MME, and MME binds to the tubulin, causing resting in G2 and M phase and tumor apoptosis, just like vinca alkaloids and so on. So what was the first trial that got this drug approved by the American FDA is the randomized phase 2 trial polatuzumab BR versus BR alone. And as we know that BR is one of the regimens that is recommended to be used in relapsed refractory diffuse large B-cell lymphoma. And that trial was a safety trial, and then an expansion happened in the second step of the phase 2, then randomization, where patients at the end got either polatuzumab 1.8 milligrams per kg plus BR, and or patients who got BR alone. And the primary endpoint was the PET-CR rate according to the modified Lugano criteria. And we can see here that patients basically responded to polatuzumab plus BR, and 7 patients have ongoing response duration above 20 months at the data cutoff when this trial was presented. And we can see that significant difference were found and statistically an overall response when patients are on palatuzumab plus BR. Also, it improved the PET-CR was improved regardless of patients receiving 3 lines of therapy or 2 lines of therapy, or patients was in relapsed or refractory status. So that's a good thing. Overall survival was significantly longer, as you can see over here. The median overall survival was 12.4 months versus 4.7 months, which was statistically significant, and also you can translate that into a clinical significance by number of months, which was more than doubled in patients who received palatuzumab plus BR. And then also the follow-up, the maximum follow-up was 45.9 months, and the median follow-up was 27.6 months. And we can see here still palatuzumab showed long-term improvements in patients who received it in overall survival and progression-free survival too. So with an addition year of follow-up and progression-free survival and overall survival, you still can see that palatuzumab is better. Here is the arm who received palatuzumab, and it was 7.5 in progression-free survival versus 2 months, and 12.4 versus 4.7 months in the BR regimen when it comes to overall survival. So we can see that patients with palatuzumab plus BR has an ongoing response for the last follow-up, around 23% of those patients, and the median overall survival was not reached in patients receiving palatuzumab plus BR because of the prolonged survival above more than 12 months in those patients. When it comes to side effects of palatuzumab, we can see the regular side effects of BR, plus the palatuzumab can cause some of the side effects, including here a higher grade of grade 4 and grade 3, higher percentage of grade 3 and grade 4 of neutropenias. We can see also some peripheral neuropathy with the palatuzumab arm, and thrombocytopenias also, and anemia. So some hematological toxicity plus peripheral neuropathy can happen. So what's coming up next for the palatuzumab is 2 trials basically that we are waiting for. Is the GHAA trial in patients who have diffuse large B-cell lymphoma, which is a phase 3 trial, and it's going to be combined with GHAA. And then the other one is a phase 3 bridging trial for patients who are transplant candidates. And we're going to use, palatuzumab is going to be used with ICE regimen, which is one of the conditioning regimens, one of the salvage regimens before transplantation. So we are really excited. I'm personally excited to see if palatuzumab improves the outcome for patients who are transplant eligible. So as we know, and just to conclude, palatuzumab is approved for patients non-transplant candidates, and it can be used in combination with BR regimen. We can see some hematological toxicities, and we can see some peripheral neuropathies. My last talk is going to be about the other agent, which has been approved recently by the American FDA. I'm not sure if there is any attempts to get it approved in Saudi. I'm just going to show you over here its place in the NCCN guideline, and I hope that the slides have been changed and you can see it. Basically, it says here it's a 3rd line subsequent therapy, including patients with disease progression after transplant or CAR T-cell. So if you have any patients who received transplant or patients who received CAR T-cell but need only after at least 2 lines of therapy, just like the palatuzumab, they can receive selinexor. So what's selinexor and why it's approved? Just give me 1 second to go back to the slide. So it was approved in the United States in June 2020, and it's approved for adults with relapsed refractory diffuse large B-cell lymphoma, and including the diffuse large B-cell lymphoma arising from follicular lymphoma after at least 2 lines of systemic therapy. So what's unique about this drug, it's a selective inhibitor of nuclear export, and it works by binding to the exportin 1 and blocking the transport of several proteins involved in cancer cell growth from the cell nucleus to the cytoplasm, which ultimately arrests the cell and leads to apoptosis. So as you can see here, I got this from the company which produces the drug, and this is the how it binds to expo1 and causes tumor suppression by preventing the cycle. And the other important thing that selinexator is 60 milligram tablet that is received orally days 1 to 3 of each week of treatment. So how it got approved, it was an accelerated approval by the FDA, and basically the SADAL trial, if I'm saying it right, is a single-arm phase 2 trial, which is a multi-center, open-label, multinational trial that assessed the use of selinexator in patients who received 2 lines or more of therapy. And the efficacy was based on overall survival response rate, so ORR, and the response duration as assessed by independent reviewer company, and it was used by the Lugano trial, just like paltusumab. The Lugano criteria, sorry, was also used just like the paltusumab trial. And the number of patients who were included in this trial were 134 patients, and the overall response rate, ORR, was 29% in patients receiving the therapy, and the complete response was 13% in the patients receiving also selinexator. 39% of the patients who achieved, 39 patients, sorry, from the 134 patients achieved a partial or complete response, and 38 patients had a response duration at least of 6 months, and 15 patients had a response duration of 12 months. So as you can see, that all patients, regardless of the subtype, got somehow response, and overall response in patients with receiving the therapy was significant to the point that it got approved by the FDA. So just to see over here the incidences of adverse events, or what type of adverse events that happened, and to me, I'm really concerned about grade 3 and grade 4 adverse events when I'm giving my patients additional or new therapy. And as you can see, that grade 3 thrombocytopenias are really common in those patients. Fatigue, anemias can be seen, and neutropenias also. Some edemas presented in those patients, and hypotension. Those are the things that I can really point out, and diarrhea. But generally speaking, it was similar to what we expect from chemotherapy. Thrombocytopenia was the leading cause of dose modification or dose reduction in those patients. And GI toxicity was around 80% in those patients who are receiving selinexator. So, and which lead to hyponatremia basically in 61% of those patients. Some reactions, some major CNS reactions that happened in selinexator, including dizziness and mental status change in around 25% of patients receiving it. So we need to monitor and watch out for those adverse events in the phase 3 trial of the treatment of this regimen. So basically, those are the 2 new treatments in the landscape of diffuse large B-cell lymphoma recently, paltusumab and selinexator. We're really excited to see if any of them is going to get registered soon in Saudi. We saw paltusumab compassionately been used in our patients. It's very important for us to, because it's very common non-Hodgkin's lymphoma in our patients. It's very important for us to push for those therapies to get really into practice, because we don't have CAR T cell to transplant them, and allogenic stem cell transplant is limited to some centers, as Dr. Khan just mentioned, which is not in all the areas of Saudi Arabia. And by that, I conclude my presentation. I hope I did not take from your time, Dr. Majid. Thank you.